Hey everyone, it's Dr. Wood. Let me know if you can hear me and if everything's sounding good. All right. How's it going, Brian? Cassette. I'm back in my home environs, so it's a good thing to be back in Florida and my usual setup. So hopefully this will sound and look maybe a little better. I can't guarantee it's going to look any better or sound any better, but that's more on a personal issue than anything else. It's a good afternoon. Yeah, it was okay. Doing some family stuff, so kind of not really a vacation, but that's okay. It was good being distant, only for the fact that I was able to not really interrupt our schedule too much, which was good. I had to pre-record that one video, but hopefully everyone got to check that out and hope it was all right. My voice is a little raspy today, but that's all right. We'll get through it. It's good to be at home recording or broadcasting than to be at a Airbnb on an uncomfortable chair. So I should at least be more comfortable. I cannot guarantee that you will. That's okay. As always, if you have questions, put them up in the chat or on the sticky board. Yes, the baby squirrel was placed back out in a tree apparently and was not to be seen again. So in my mind, I will say the mama squirrel came and picked up the baby and it is living happily ever after. Who knows if that is true or not? We'll see. So, John, thank you all for joining me today. I applied again at university to get the dose of your lectures. Don't do that. It's you guys can only handle a single dose of me. It's very easy to overdose on my material. It's unfortunate because you got 2 classes with me this semester, and then farm is actually double the length next time, so it's almost like having these 2 put together. All right. Well, it is almost 12:30. It is 12:30 on the dot. So let's go and start the recording here, and we'll see how it goes. Thank you for joining me again. We are continuing on with our discussion of Epi and biostatistics and all of that. We're going to get into probably lectures 3 and 4 here. Again, if you have questions, please post them up. Checking right now, nothing on the sticky board, but I'm sure I'll find a few things going up there shortly. But let's keep talking about our confidence intervals here for a little bit, because I think we touched on them briefly last time. We were talking about what does confidence interval even mean. We're going to get into more details here. So we're going to talk about sort of how we're going to apply confidence intervals. We're going to talk about survival data too. Unfortunately, biostatistics in epidemiology can be a bit of a bleak topic, but it deals a lot with death statistics and things like that. But unfortunately, death is actually a really good like yes/no binomial sort of event. It's very well defined in terms of when someone has died, and that's probably why they use it a lot, at least for illustrative purposes. But it's important, right? Because we're seeing a lot of death going on nowadays due to things like coronavirus, and so we'll see how that can be, how we can apply this information over to that, as we'll see here in just a few moments. So when we're talking about confidence interval of a proportion, remember that when we use confidence intervals, we're typically talking about like a smaller sample set. So we're dealing with like maybe 30 people, right? Our N is 30 or maybe 100, whatever the case may be. And we're trying to use that info gathered from that sample and then generalize it back to the greater population. Because as you recall, we can't really know what the actual mean value of something is for the general population because we can't measure everyone, unfortunately. And so that's why we use these smaller data sets to try to make generalizations. Now, are those going to be correct every single time? No, and that's why we end up using these confidence intervals. And so we're going to talk about what that really means. And so when we're looking at this, it's basically saying that if you were to take that mean value and you have that range of confidence intervals around that, you can be 95% sure that the actual population mean is going to fit somewhere within that range. And so the width of that range is really important because, say we're going back to the temperature example and we're trying to figure out what the average person's temperature is. And you get I'm 100% sure it's somewhere between 0 degrees centigrade and 100. Well, yeah, that's all well and good. It's probably true. It's 100% true, but it's not super useful. I don't think anyone's going to be getting anywhere near those extremes. So ideally what you're going to want to do is to try to get the greatest assurance possible. So sticking somewhere between the 95%, maybe even 99% in some cases there. But we want the smallest width of that confidence interval because, I want to use something that's actionable, something that's actually informative. So by using a smaller confidence interval, it's going to be more informative. I'm going to have a better idea of what the actual true value is. Right. So anyway, so it's pretty complicated in terms of how that's calculated. I don't know how to do it, to be honest. A computer would do it for me if that was the case. And in fact, something a lot of you may not know if you've never done any kind of biomedical research before, but frequently, like the researchers, they don't know how to do that stuff either. Most of the time we end up contracting out with a biostatistician that actually does all the work for us from a calculation standpoint. When I did my research during my fellowship, we were doing a lot. We're doing a retrospective review on coral snake envenomations, and we designed the study. We knew the sort of the comparisons we wanted to make, and then we sent it off to a biostatistician. They ran the numbers and then gave us back the info, and then it was our jobs to interpret that. So similar to this class, I'm not going to show you how to make a confidence interval, but I will expect you to know how to interpret it by the time that we are done here, right? So anyway, so what you're going to find is in a lot of the medical literature, when you look stuff up, that journals require the use of a confidence interval in addition to the p-value. We're going to talk about the p-value pretty extensively in the next lecture, the next PowerPoint sets. But, p-values are good. And I think most people probably have heard of a p-value like, wow, we found a p-value less than 0.0001. Look at these great results. And honestly, sometimes having a low p-value like that doesn't really mean a whole lot from a clinical standpoint. But confidence intervals are quite useful because it's more descriptive of the data rather than giving you what the p-value shows you, which I'll talk more about that in just a little bit. And so again, when you're phrasing it, you can say something like, we're 99% confident that the true value of the parameter you're looking at, whether it be temperature, blood pressure, or whatever, is in our confidence interval. Or 95% sure that the confidence interval contains the true population value, right? And again, in the case of 99%, you're going to be right 99% of the time. Assume you're following some of the assumptions we'll talk about later. Whereas with a 95% confidence interval, we're going to be right 95% of the time. And for most things, 95% is good enough, right? You're going to find a lot of things are just good enough in medicine, right? We're never going to be 100% sure, unfortunately. Now, as you recall, the width of that confidence interval really depends on a couple of different factors here. So for one, the sample size is going to have one of the biggest influences on this, and the one of which the researcher can have sort of the most control over in a lot of cases. Meaning that the larger the sample size you have and the better that you're approximating that population that you're trying to generalize to, the smaller the confidence interval is, because you're going to be much more certain because you have a much more representative sample there, right? So that's one thing you'll see there. So typically when you have studies done with very small sample sizes, maybe 12 patients, 15 patients, you're going to find that it will have pretty wide confidence intervals, right? Because of that smaller sample size. If you were to increase that by a factor of 10, it would significantly shrink that down. I have some pictures to show you that will make that a little bit more concrete here in a moment. The size of the standard deviation is also important. And if you recall from last time, the standard deviation is that variability of the data around the mean, right? So if there's a ton of variability, if a lot of the values are far off from the mean, you're going to have a much larger standard deviation. And looking at the calculations, that's also going to factor in and give you a much wider confidence interval as well. So the tighter the data is centered around the mean, the more compact that data is, the lower the standard deviation, and thus the more narrow the confidence intervals are going to be there, right? And then the third thing here, which researchers always also control, but this is usually pretty well set by tradition, is that you can set that degree of confidence. And so the higher the degree of confidence that you're saying as you get closer to 99%, the more leeway you have to give yourself. And so you have to make those confidence intervals wider. Keep in mind it's calculations, so it's not like I'm, consciously saying, okay, we'll make them a little bit wider. I want to hedge my bets a little bit here. It's actually done via the calculations there, but this is what goes into it. The more unsure that you are, if you only want to be, have a 90% confidence interval, for instance, you can make those confidence intervals more narrow, right? So the higher the degree of confidence, the wider the confidence interval, right? So it's a good idea to have an understanding of how these different factors, if they vary, what sort of effect is that going to have on the width of the confidence interval? Okay, so have a good idea of that. And pictures I'll show you in a moment will make that more clear. And again, the confidence interval has to be larger if you want to be almost near 100% certain that the true population value actually lies within that range there, right? So let's look at an example here. Again, I apologize if this is dour, but it's still illustrates the point fairly well. But let's look at deaths of premature babies, right? It is what it is. But this is a study done back in 1993. And basically they were looking at survival rates in premature infants. And so they were retrospectively, which, means they were looking backwards in time. They weren't collecting data in real time. They were looking backwards. So a lot of like chart reviews and things like that you'll see are done in a retrospective manner. And so they're looking at all the premature babies that were born between 22 and 25 weeks gestation at a particular hospital during a 3-year period. And so what they're looking at is that of the 29 infants born at 22 weeks, they found that none of them had actually survived to 6 months. And that 39 infants born at 25 weeks gestation, so just 3 extra weeks there, cooking in the oven, so to speak, they found that 31 had survived to at least 6 months, right? And so what you can do is you can take the averages there and actually calculate a confidence interval around that, because you have data on 39 infants here born at 25 weeks, but if I were to then extrapolate that out to all babies born at 25 weeks, you probably won't find the same exact percentages there. You're going to find that we have to give ourselves a confidence interval in order to try to capture what the true population average would be of all those babies born premature at 25 weeks, right? So looking at the confidence interval is going to be calculated when that sample is hopefully representative of a larger population. Now, we'll find there's some ways that you could violate this based on the type of data that you're collecting, based on a lot of things. So we'll look at that in just a moment. But basically, we're trying to make inferences about that population, right? So especially if we're knowing that we're going to generalize this out to the population, right? And so you get to define that population. Are you saying all premature babies born in a particular state, in a particular country, in a particular planet? That makes a difference too, because you're going to see that you're making some different assumptions there, right? So anyway, so looking at the averages of the survival rates here, obviously none of the babies survived. They're born at 22 weeks, so their average survival rate was 0%, or 0% of them did survive, right? Versus 79.5% had survived by 6 months here in the 25-week group, right? And so what we can then do is get a confidence interval around these values here and then use that to extrapolate out to that larger population. So let's see what that would look like. And so what you can see here is that for infants born at 22 weeks, the 95% confidence interval ranges from 0 to 11.9. Notice that it captures the average, or the percentage survival rate that we got from this value here, which was 0 in this particular case here, right? Now notice it doesn't go beyond 0 because you couldn't have negative values in terms of survival unless you had someone that was starting out dead and became alive, which doesn't make a whole lot of sense, so that wouldn't happen. But then looking at the 25 weeks, we can see the confidence interval ranges between 64 to 91%, right? So what we saw in the previous slide is 79.5% survival in that 25 week. And then we see that the confidence interval will then range around that, right? So down to 64%, up to 91%. So if I were to then extrapolate this out to the whole population of premature babies born at 25 weeks, I would be 95% sure that the actual survival at 6 months would be somewhere between 64% and 91%, right? I'm 95% sure. So I'd be wrong 5% of the time, but 95% of the time, which is pretty good, I would be capturing the actual population percentage somewhere in there, okay? And so looking at that, we can use that 95% certainty to then, basically extrapolate that out and figure out the overall proportion of those surviving infants based on that confidence interval there. To use a slightly less depressing example here, let's look at polling voters, right? So let's say we were taking 100 randomly selected voters before an election, and I promise I'm not going to be too flippant about any of the current political climates going on right now, so we're going to keep this as fictitious as possible. Again, my only political stance I'm going to take here is you do go vote, so please do that. Oh, wait, let's see. Nicole asked a question. She said, how were you able to get those percentage ranges? Is that from a math generator? Yeah, so Nicole asked a very good question. Where do you actually get these values from? And so how these are calculated goes back to using, one, the degree of confidence that you want. So that 95% factors in. You're looking at the variability of the data, the standard deviations based off of what you collected there. And then you're looking at the sample size as well. So all of that goes into a specific calculation, of which I'm not going to show you because I don't really care. I don't think you guys really care either. But it determines what these confidence intervals are, right? So it calculates it from the data that we feed into the system, whether it be SAS, it's a common program used to run stats or whatever the case may be. So that's where those numbers come from. Anyway, so back to the polling. So let's say we polled 100 random people before an election, and 33 of them said that they were going to vote for your candidate that you were interested in. So 33%, right? 33 out of 100 there. And so, okay, what can you say about the proportion of all voters who will vote for your candidate, right? So could you say that if you then extrapolated that out to the whole U.S. population, that your candidate would only get 33% of the vote? Well, there's some questions you have to ask yourself. So one, is your sample representative of the population of voters, right? So if I only polled people who are in Florida, can I then extrapolate that out to would that be consistent with people who are voting in California or people who are voting in Montana? That would be quite different, as you might imagine, especially depending on, who the candidate is and all sorts of different factors there, right? Also, there can be sampling errors that occur there, right? So you can find, that the sample is going to contain, the sample that you're looking at, whether it be in Florida or even to the county specific or whatever, that you may be having a bias there, either a smaller or a larger fraction of people voting for a candidate than the actual overall population there. You have to consider, is your population that you're looking at, that you poll, is that actually representative of the larger group that you actually are interested in, right? Now, again, when you're seeing here, it's good that if you could then come up with a confidence interval to account for that, because you're not going to get 33% on the nose if you then extrapolate that out to a larger population, but you give yourself some wiggle room here. So you can say with 95% confidence that you can say, okay, the number of people that are likely to vote for your candidate is somewhere between 24% and 42% based off of this initial information that you're putting in there, right? Just like if you were, say, for instance, dealing with a mother who had a baby born at 25 weeks and she says, well, what's the chances that my baby's going to survive, right? You don't want to tell her specifically, oh, it's 79.5%. Because you don't want to lock yourself into such a specific number there, because again, the fastest way to prove yourself wrong is to say things absolutely, right? So by giving yourself a little bit of a wiggle room, you can say, well, there's probably between 64%, 91% chance that that baby's going to live. Now, it may not be as reassuring of a number, it may not be as satisfactory of an answer, but that's the truth. That's what we have based off the data that we're seeing here. So again, you're giving yourself some wiggle room to be wrong and trying to give yourself that room to say, well, the actual population is probably somewhere between, in this case here, 24 and 42%, right? You're 95% sure. Even then, 5% of the time, you may not actually capture it. It could be outside of this. It could be down to 20%, or it could be up to 50%. Who could say, right? So look at some assumptions of using confidence intervals around proportion here, right? So Marley's asking, sorry if this is already stated, where does the 95% come from? Or is that a standard definition of CI? So it's a little bit arbitrary, but it's historically just what we've used, right? You could say 99% confident, that give yourself even more confidence. You could say 90%. The trick is that there's trade-offs either way. So you tend to find that the number of false positives and false negatives you get can actually be affected by how confident you want to be. And so I'll show that in more detail here in the next lecture when we start talking about like null hypotheses and things like that. So boy, if that just doesn't wet your whistle and get you anxious for the next lecture. Just you wait. P-values and null hypothesis. Boy, it's just appetizing stuff here, but important stuff nonetheless. This is why I think it's really important that you guys take this course. But so let's look at the assumptions we're going to have about these confidence intervals of a proportion itself, right? So we need to assume that the sample we're looking at is random or representative of that larger population, right? So if I'm trying to extrapolate out, for instance, that voter example, if I just went to, say, Walmart and I polled 100 people there and expected that to be representative of the whole population, I may get one set of results, which may not be completely accurate, versus if I went to like a Whole Foods, you might get a totally different set of results there, right? Different, clientele perhaps, different, political leanings, perhaps. Who knows, right? So there's a lot of different things. And so you have to assume your sample is representative. And there's a lot of ways to violate that based on how you're collecting your data. So for instance, if we're going back to the baby example, well, what if we were, somehow inadvertently selecting out for patients to be sicker, right? So for instance, if we were dealing with, mothers who were IV drug abusers, right? That probably has some detrimental effect on a developing fetus. And we had a higher proportion of women in that 22-weeker group, maybe that's affecting the results somehow versus if we were using a more healthy population, right? And again, this all goes to how you generalize this out to the larger group. Or this is actually kind of interesting here when you're looking at the voter example, if the sample really wasn't random. So there's an example back in 1936, this election between Roosevelt and Landon. What was interesting is that pollsters were using phone books and auto registrations in order to poll people randomly. And so that's making a lot of assumptions already. So again, if you were thinking back to 1930s, people had to have a phone to be in the phone book. People had to have a certain amount of wealth in order to have a car. And so you'd be selecting out for people that maybe are a little more affluent, or a little bit higher up on the socioeconomic spectrum, and maybe missing out on a lot of people who are further down and didn't have the means to have either of these things there, right? So now you're selecting out for a certain subset of the population that's not truly representative, and you may get altered results, right? That's bias. That's biasing your results in one direction or another. Or nowadays, if you were to poll people and they only had, they were polling people that had landline phones, probably wouldn't get very many people even to participate in the first place, but you might get a lot of people like my parents, for instance, that still have a landline, right? I'm pretty sure none of us do at this point, but you get my meaning. So the other thing too is they need to have independent observations here. And so this is important to make sure that each sample of your, or each observation within your sample, so each person participating, as the case may be, is independent from one another, right? So for instance, if you were looking at the baby example, you wouldn't want to use twins because, they'd be born at the exact same time. They're sharing a lot of genetic and environmental factors that could have an effect on their survival, right? So because they are linked together, they may skew the data one direction or another. So that would be a violation here. So we're talking about independent observations, and twins automatically violate that, right? Or for example, if you were doing the polling example and say you were a pollster and you called up somebody, and you're talking to their husband, the husband of the group, and they say, I'm going to vote for this person. You say, hey, why don't you put your wife on the line while you're here and tell me who she's going to vote for? People who live in the same household may be more likely to share similar political views. And so that, again, could bias your results, right? Or for instance, if you were, polling in certain parts of the city and not others, right? So any of these things could be introducing bias. And this is why it's really important when you are evaluating journals is that you're looking at how they collect the sample, right? And this is something you're not going to find in the abstract because that's kind of the nitty-gritty nuts and bolts of the study. You got to look to see how are they collecting these people? Was it a truly random sample? Did they look for means of controlling for differences between the groups? Were they pulling people that may skew the data one way or bias it one way or the other? And you can look at that and determine, okay, well, can I really take anything away from these results, right? So if they were doing a poll and they were only collecting data from people in a very affluent area of the city, then I'm not going to be able to take a whole lot away from that if you're trying to then predict what everyone in the city is going to vote for, right? Because it's being biased by how the data was collected in the first place. Another thing too you're assuming the data is collected accurately, right? So in the case of infant death, that's pretty easy to tell. That's either yes or no, they're alive or dead. But in the case of like doing something like a survey or polling or something like that, that can be really important in terms of how questions are asked, because even changing wording can be really important in terms of the results that you're going to get. And so, for instance, what if you had a pollster call you up and say, well, only an idiot would vote for this person. You're not an idiot, are you? You may be more inclined to answer one way or another as a result of the way the questions were asked. Similar to a lot of studies that use surveys. Frequently, what you want to look for are surveys that are established, or surveys that have some degree of professional clout to them, so to speak, that have been validated, such that you know that if I were to use that same survey and apply it to other samples, I should get similar results. I remember when I was in fellowship training, we would have, all the residents would do research projects, and one of them had done a survey to see like how useful pharmacy services were in some kind of behavioral health counseling or something like that. And so she went over all these results. And I said, well, what if you like were to change the wording of these questions? Do you think that would have much effect on the results? And you could tell the person hadn't really thought about that. That's something really important to consider, is like how the wording of things is important. You look at the surveys that you do for all your courses and all your professors. If they change the wording of that, would you answer differently? Maybe, maybe not. But those are some things you want to consider here. Now, getting into like, what does that 95% confidence interval really mean? Again, it's saying that we're going to be right. If we say 95%, we're right 95% of the time, right? And that other 5% would mean that the confidence interval that we're reporting 5% of the time, or there's a 5% chance that the actual population average would be outside of that and that would be incorrect, right? So this is an example here. Let's say we're going back to our urn example. We're looking at an urn. It's filled with 100 beans, right? And it was 25% red and 75% black, right? So we know the actual proportion here is, right? Now, we're not going to know that when we're doing actual science in people, because again, we're never going to know the whole population average for anything. But let's say here we actually are controlling for this and we know it's 25%. Now imagine you had 20 different experiments run, and you had one person pick out 15 beans. So the N is 15 in this case here for each of these experiments. And what you can see here is that, very few people pulled out exactly, or got the red bean exactly 25% of the time. So again, this line here is the average, and then the confidence interval is going to be on either side here. But what you notice is out of the 20 examples here, 19 of them do contain the actual correct mean value. Even though no one actually pulled out 25% red, you can see here that the confidence interval included the actual mean. One of the times, though, that 1 out of 20, or 5%, did not get even close. The confidence interval did not encompass that 25%. So in this case here, we would incorrectly say that, okay, well, the actual population average of red beans in this case here is, between 75% and 30%, whatever that happens to be. And that would be incorrect, right? So that'd be a 5% chance would be incorrect based off of that result. The rest of the time, though, you're right. It does include the actual 25%. Okay, that's kind of what we're talking about here. We're saying we're 95% sure that the true population average is contained in these bounds of the upper and lower limits of that confidence interval, right? So when I say confidence limits, that means the upper end and the lower end of the confidence interval. The interval itself is contained within those limits there. So that's that range, okay? And when we're saying an estimate, again, we're using calculations based off the data that we're collecting in order to get that confidence interval. So it's an estimate, but it's based off of actual numbers, right? It's an actual calculations done. We're not just kind of guessing at it, so to speak. So again, we're calculating this because it's impossible to know what the actual population true value is. And so that's why we're using this data to try to extrapolate out to that larger population using a smaller sample. And as I mentioned, and just like, Marley was asking, there's nothing special about 95%, right? There's some drawbacks, either going the higher confidence interval or lower confidence interval, which I'll talk about a little bit later here. But again, it's a term used most commonly to describe the amount of confidence that you're looking for. But just know, and we'll look to see if you change that degree of confidence, what that does to your interval here in just a moment. So actually, this is that moment right now. So let's say we're looking at our average values. It's going to be the line in the middle of this box here. And then what you notice is the confidence intervals change based off of the degree of confidence that we're looking for, right? So 90%, 95%, 99%. So when I say I'm 90% sure that the actual true population value lies within these range here, you're going to be wrong 10% of the time, which a lot of people that would sound, the chance for being incorrect is too large at 10%. So you want to be more sure. But to do that, to decrease the chances that you're going to be wrong, you have to give yourself more wiggle room, right? You have to give yourself more values for the actual true population value to fall into. And so this is why you have to widen out that confidence interval when you go for a higher degree of confidence. This is all using the same data to calculate these. It's just the only factor you're changing is that confidence interval, right? And to be 99% sure, such that you're going to be wrong 1% of the time, you're going to see that you have to go even wider than that, okay? So the less confident you want to be, the smaller your confidence interval is going to be. The more confident, the wider it's going to get, okay? Now, again, as I mentioned, sample size is going to have a really powerful effect on this in terms of shrinking your confidence interval too, because the bigger sample size, the closer you are to actually estimating what a true population average is going to be, right? What the actual population looks like, the bigger sample size is. So as you notice here, if your N is 10 versus 20, 40, 80, and 160, you can see here that it drops down pretty dramatically. So this is why we like to use sample sizes that are larger, although logistically it gets to be more difficult, or maybe it's hard to find enough patients to even have the condition you're looking for. You can probably find, millions of people that have hypertension, but when I do my research on coral snake bites in Florida, there's like 50 a year. So, my sample size is going to be kind of limited by the fact that it's a pretty rare condition in the first place. Unless I release a bunch of coral snakes into playground or something, but then you get into all kinds of ethical considerations, and I just don't want to go to jail for that sort of thing. So. Now, confidence intervals do not have to be symmetrical around the average, right? Around the actual proportion that you calculate there. It can be, sometimes you're hitting upper limits. Like, so for instance, if you were to look at the average GPA for your class and then look at the confidence interval, it might bump up against that 4.0 because you can't go higher than that. So in those cases there, it can be asymmetrical. So just something to know there, it does not have to be equal around the average. It can sometimes range, especially the further away you get from like 50% proportions, it tends to skew it a little more, as you can see here. Okay, so now switching gears, let's talk about confidence intervals in terms of survival data, right? So we're looking at, let's not just focus on people who are dead, let's focus on the people that are surviving, right? Let's be a little more positive around here, people. Come on. Now, frequently if you're looking at something, you're looking at outcomes. If it's something that's a very binary sort of thing, so alive or dead, you have recurrence of cancer or not, things like that. See, snakes on a playground, the plane was only the beginning. Yes, that's my PG version of the movie, Snakes on a Playground. But be careful, they're still warm, and snakes are pretty active in Florida, so I think it's good that we're all inside. Actually, that's interesting. I'm kind of curious, if I were to look at the normal snake bite data in Florida, has the proportion of bites gone down as a result of people social distancing and being inside? Good question. Let's see. Rashani is asking, if the CI is not symmetrical around the average, would that mean that we wouldn't have a normal bell curve? Not necessarily. So when you're looking at like a bell curve, again, you're looking at the distribution of the data. The confidence interval isn't really showing you the spread of the data so much. It's more of an estimation of what the actual population average would be. So if like you took the average of that bell curve, then trying to figure out, okay, well, what's the range in which the actual population fits into this? So not necessarily, they're not necessarily linked quite in that way. So anyway, so going back to the survival data here, again, what you can see is that you can use things like what we call here a Kaplan-Meier curve. And these are really handy when you're looking at things, especially like death is a good one, right? And so if you hear like a Kaplan-Meier curve, this is what it's looking at, is looking at survival data. But it can really be any kind of binomial thing that can really only happen once, right? So for instance, if you were to look at catching the common cold, right? That can happen several times to a person. And so that wouldn't be a really good thing to include on a curve like this. But if you're looking at like death, since that presumably only happens once, unless some means of resurrection. That's not going to happen, right? So death is a pretty good one you'll see here, but really any other binomial thing that can only happen once, it can fit on these sorts of curves. So again, it has to be a one-time thing, cannot recur. And then the other important thing when you're plotting these out is you actually have to know the actual time at which something happened here, right? So you have to know specifically when did that person die, because we need to know the actual amount of time that they were included on these kind of curves here. So I'm going to go into more details on how these work. So a lot of times though, we have to do things called censoring the data. Now that's not saying that like the data is, cursing or something like to censor it. It means that if you don't have the information to be able to plot out like when this person died, or, let's say for instance, you're looking at death due to COVID-19, but the person died in a car accident in your study, do you include that? Like, do you censor that data? Do you try to exclude it? What do you do with that? And so this is when we talk about censoring survival data. That's kind of what we're talking about. Sometimes you're holding a study and people move away, or people don't want to continue taking the drug, or they don't want to do whatever, and they just fall off the study, right? So in some degree, there's going to be attrition in your studies. And so that can affect the data as well, right? So they're lost to follow up. Or sometimes like you have to end the study at some point. It just doesn't go on forever. Some people are still alive at the end of that study period too, right? So that's also important data that you want to take into account here when you're trying to plot out these survival curves. And so when I mean censor in terms of the data, that's what I'm talking about, is you're looking at the observations and removing them from the analysis, but you're still accounting for them, right? You don't want to read a journal article that says, okay, we included 100 people in this group, and here's the data for 87 of them. And you're like, well, what happened to the other 13? Like, what happened to those people? You should be a little skeptical if you can't really figure out where all those numbers went, where those people went to in their analyses, right? So that's an important thing to consider there as well, okay? So anyway, so we're going to take into account how long these people are in the study, and then either when they die or when they leave the study for one reason or another here. So let's take an example here. Let's look at 7 different patients. You can see too here that not everyone joins on the same date. Frequently, a lot of studies will have sort of rolling entrances into it, such that people can come into a study a year or two down the road, for instance. And then you can see the ending date here, and you can see kind of what happened to these patients here. So of the 7, we have 4 that died as a result of whatever the study is looking at, and we have 1 person that died in a car crash, which is unrelated to whatever they're researching there. And then for 1 person, they were still alive by the time the study ended. And in these kind of things, you don't just kill everyone at the end of it. That would be kind of inappropriate. And then 1 person moved and they weren't on the protocol any longer, so they were they got censored as well. So the people that died as a result of the actual whatever they're looking at, whatever outcomes they're looking at, or intervention, these people are included in the analysis, and then you would censor these people here as being indeterminate, right? You don't know how long this person would have lived for looking at, at the end of the study, right? They could have lived for another 20 years and we just don't know. So then we're going to go ahead and plot it on the curve here. So again, 7 patients in the study, 3 of them are censored as a result of the fact they're either alive or we don't know how long they would have survived for. And again, people that live for a long period of time, we just can't collect all that data. You can't just keep collecting data for 30, 40 years. It is not feasible in a lot of logistical senses there, okay? So what you can actually do is when you're actually plotting the data, you have the amount of time that they were in the study for. So 1 person was in for 4.07 years and 1 person was in for 6.17. And you can see whether or not they get coded as a censored point or not. So for instance, here 3 people got censored, so they get coded as a 0, and then everyone else gets coded as a 1, right? So there's a couple different ways you can plot the data here. The most common one you're going to run into is this Kaplan-Meier method, which is that kind of stepwise looking curve as we saw a few slides ago. And basically what they're doing is that every day they calculate the fraction of patients who survived on a particular day. And then each time someone dies, there's a tick down. So it's kind of, it looks like a very shoddy job at building a set of stairs or something, right? Because again, if you go a long time where people are surviving, then you may have a long plateau and then it dips down once a couple people die, for instance. We'll see that they also will account for the censored data there, and these are going to be generated by the computer, as you'll see a couple different ways we can graph it here. Now again, when you're looking at these curves, everyone starts off at the very left side of the curve. They all start off at the 0 point, and you're looking at how long that they survived in the study for, not necessarily having people that joined later, they're not going to show up later on in the curve. Everyone starts kind of at the 0 point. And so you can even calculate confidence intervals based off of this. And so I'm not going to belabor these points here, but you can see at these different points in which people either died or they got censored, you can come up with the percentage of people that are still alive, the proportion here, and then you can get confidence intervals around that. So if you were to say look at a certain cancer treatment, or let's say we're looking at people who were infected with COVID and we were trying out a new experimental drug on them, like remdesivir or something, and we're looking at the percentage of people still alive, you could then get these confidence intervals, and you could say here, okay, well, if I were to then extrapolate this data out to the larger US population of people with COVID-19, and then I was to look to see, okay, well, this percentage of people would still be alive around this range here between 5% and 69%, right? So these are things we can generate and then apply out to the population itself, which can be helpful. And you'll see this a lot for like cancer treatments too. So for instance, I'll look at like cancer recurrence as like a yes/no phenomenon, or 5-year survival for a lot of cancer, things like that. And again, a couple of different ways you can plot it out. This is going to be the most common one. This one right here in the bottom right. Notice here, this one on the bottom left has the confidence interval sort of shaded in. You see how kind of wide it is, the upper and lower limits there. Now, one thing to note here that's really important is going to be this 50 percentile mark here, right? So the point at which 50% of the people are still alive in the study is going to be called the median survival time. And that is important because we're going to see that that's how we're going to start to compare these survival curves to one another. And we use a median for a very specific purpose. Note here, there's different ways to show the censored data. So for instance here, these little dots, you can see the censored points. Here's a little tick mark on the line. But notice here, each time there's a dip down, that is a percentage of the people that are no longer alive in the study. And you go, why? Well, everyone's surviving. And then you get another tick down as people start to die off or they get censored. Okay. So as I mentioned, median survival is an important concept to get here because that is going to be a good way for us to summarize the data. Now, to get the average survival time, I would have to follow everyone in that study until everyone of them is dead, because you got to know how long they were alive for to get the average survival time, right? But we're not going to do that because it's logistically impossible and we don't have time to follow people for 60 years, depending on how long they're alive for. So what we can do instead is look at the point where we hit the 50th percentile, because that's the median value. Already, once you get 50% of the people still alive, we know that's the 50th percentile, right? Because we know how many people we're evaluating, whether it's 100 people. When 50 people are still alive, that's your median survival time, right? And that's helpful because, again, I only need 50% of the people to meet the outcome that I'm looking at instead of 100% to get the average. And then you can then compare these to other curves, right? So if I was trying out a new experimental treatment for COVID-19 versus, supportive care, I could then compare the median survival time to see which one was longer. The one that's longer median survival time, that would appear to be the more effective treatment for those patients, right? So those are things we can end up using with these survival curves to kind of help us out determining, what's the best treatment, or if we're just describing a population to see how long they survive for given whatever condition, whether it's cancer or whatever, right? So, and again, as I mentioned, 5-year survival is just a common thing you'll see with cancer. Again, this is another arbitrary thing. It's just something that has been used historically for a long time and will probably be continued to use for a long time anyway, right? So some assumptions when we're looking at survival analysis. So this is an important thing here. You have to make sure the assumptions stay the same, especially if you're running a study over a long period of time. So one thing, you want this to be a random sample. Again, you want to be able to generalize this out to a larger population. So whoever you're including should be representative of that sample. If it's not completely random, then you may have some biases that are sort of skewing it either to longer or shorter survival times there. So that's one thing to note. Again, another assumption is independent subjects. You don't want to have family members that are together because they share genetics, which could predispose in one direction or another. You want to make sure that you're not having siblings, any twins. You don't want to have people being included in the study twice if it's something that they could be counted for and then come back into the study. Everything has to be independent from one another. Okay, so that's another assumption. Now, this is where it gets a little more interesting. So the entry criteria are consistent, right? So again, the entry criteria should not change over the months and years of enrollment there. So for instance, things like improved diagnostic tools could identify subjects earlier and affect the survival time, right? So for instance, if we were to have a different, say, imagine, COVID-19 from, say, March to now, we have a lot more means of testing people. Maybe we're better able to identify asymptomatic individuals, and then we can include them, because if you're asymptomatic but you still have it, then we want to know your survival time too, right? So those things need to be explicit in terms of the study and how they define who we include and how they get included, right? And then the endpoint has to also be consistent as well, right? So when you're looking at all the deaths, are you censoring them if they die for things unrelated to the study? Oftentimes, many studies will look at what they call all-cause mortality, and they'll include things that have nothing to do with the study you're looking at. So if you're looking at, a cardiac study and you're looking to see how many people die from a heart attack, but someone dies in a plane crash, well, you still include that if you're doing all-cause mortality. And sometimes what they'll do is they call trying to think of the term here, it's escaping me all of a sudden. We include what they call intention to treat, and so even if you have people that leave the study and you have no idea how long they would have survived for, you can sometimes do sensitivity analyses to exclude them and see what your data looks like, and then you include them back in to see how much it skews it. And that can be helpful because it kind of tells you how much of your results are being affected by the censored data there. We'll talk more about that later, but there's ways we can kind of get around this a little bit. But again, it should be applied consistently throughout the study. If you define recurrence of cancer, or if you define death, or whatever the outcome it is that you're looking at. Starting time needs to be clearly defined. Again, it needs to be an objective date that you're including them, whether it's a first diagnosis or it's a hospital admission. You don't want to do it based off patient recollection, because you tend to find that people have faulty memories, or they may say, I barely remember what I did last week, and it was pretty notable because I was in a different city. So recollection is not going to be useful here, but if you have something like when they got an ICD-10 code for something, that's pretty good because that actually has medical documentation. You have a timestamp on it. You know when it happened. And again, patients who die early, let's say before they even get treatment, should not be removed. That's what we call that intention to treat analysis, where we go ahead and include them anyway, even if they didn't get the intervention that we're looking for, because that tries to limit some of the bias that can be included there. So if your intention to treat, that's where you're including people, even if they never received the treatment in the first place, or they ended the study early, anything like that, that's called intention to treat. Next, censoring unrelated data to survival. So again, here it's only the analysis itself is only valid if we know that the reasons they're censoring are unrelated to survival. So for instance, if you're doing a drug trial and someone drops out because they were getting really horrible side effects from the medication, right? Or they felt like they got better and they did not need to, they recovered and they didn't want to partake in the study anymore. They thought it wasn't really relevant to them anymore. That can all skew your data. So you need to know if they're going to censor things, they need to be pretty explicit about why they censored that data to make sure there's not anything that sort of can introduce bias there. So that's something you want to note. And then you want to see here also the average survival does not change during the study. And so this is only going to be good if you're following people for like a long period of time, because you can find that, nature of diseases can change. For instance, if death rates for COVID-19 was rapidly changing from say March to now, that could affect survival data quite significantly. Or perhaps, with treatment, if treatment has changed, frequently when you have say like a new gold standard, you don't want to keep people from getting the treatment that they need, right? So I'll give you a good example of this. Just recently, we had a study we were doing at Nemours. It was for a condition called spinal muscular atrophy. And it's a condition where basically it's a autosomal, recessive condition, but it's something to where basically these children don't produce a certain protein, and it makes their skeletal muscles just basically wither away, and eventually they die of respiratory failure at a very young age in a lot of cases here. It's a really horrible condition, but we had a study where we were actually injecting these patients with a virus that actually helped to code for the specific protein. Actually injected this DNA into the patient own DNA and allowed them to produce this protein. And they found such significant benefits for using that they actually stopped the study early, because it was unethical to continue not treating the patients that were in the placebo group because of the fact that they got such good improvements that they actually got the actual drug, right? So sometimes you'll see that things like that can change to where you may need to either end a study early or make sure that you're not withholding valuable treatment if it truly is beneficial to the patient. So good on them. I'm glad we got better treatments for that condition, because it really is quite a sad one. But anyway, as I mentioned, why do we do median survival time rather than average? And because to calculate the average, you'd have to have every single patient die versus only having 50% there. Yeah, so Kaylee's asking about the ethics there. Yeah, so just like with the HIV trials, like it would be unethical to give an HIV patient placebo when we know that survival is much better if you actually are on heart therapy or highly active antiretroviral therapy. So ethics do play a role in that. And actually, there's something called the Institutional Review Board, the IRB. Ever heard of that? And they're responsible for making sure that all the studies that happen under their purview actually are ethically sound and all of that, to make sure that we're not putting anyone under undue harm. So like NSU has their own IRB. A lot of places have their own institutional boards. So that's it for this section. Let's see, we're just about at the hour mark, a little over an hour. So if you have any questions, let me know. Otherwise, I'm going to open up the next thing here. Let's look at the sticky board here. Okay, so first question is, will the test be based on definitions or evaluating statistics from case studies? Yes. I'm just kidding. To elucidate more on that, yeah, you do want to know your basic definitions here. So that way, if I do have, for example, a snippet of a study or something, or if I give you a scenario, you can determine what specifically I'm talking about when I say things like a confidence interval or a standard deviation or things like that, right? How should we be studying for this class? Any advice? Let me touch back on that towards the end of the class, just so I can keep rolling on here. Aaron's asking, but it wasn't considered unethical until the treatment was proven successful. Is that correct? Yes, very good, Aaron. And there's actually some good, I'm not sure, did you watch, and the band played on, I think that's a movie that Dr. O shows you guys, but there's a lot of really good documentaries about the early days of HIV treatment. And what was really crazy is that, not crazy, but it was just really kind of fascinating, is that in the early days, in the 80s, I mean, so many people were dying from this, and there was very little to go on in terms of like, dude, what works, what doesn't work. We were just kind of shooting in the dark. And what was interesting is even people that got included on some of these trials, they would even like not take all of the medication because they wanted to give it to some of their friends too, because they didn't want them to die. They said, if anything could give us a chance, please let us have this, even though ethically we were like, well, we don't know if this is going to kill you or cure you, right? So it's very difficult, especially when you're dealing with a really at-risk group that was dying from something that was just really unknown at the time. So it's pretty nuts. Kaylee's asking, please correct me if I'm wrong, but this ethical board was established because of the Tuskegee cases. That is a good question. The Tuskegee cases was a pretty good example of why we need IRBs. I'm not sure if that was the only thing that led to that or not. I'd have to do some more research on that, but that's a really good one. That was actually where they were doing studies where they were, I'm not familiar with all the details. I should probably be looking this up before I talk about it. But, they're having these military men, getting things like syphilis and not treating them. And it was really awful. So, yeah, that was one of the things. I'm not sure if there are other things that instituted or that caused that to occur or not. But definitely a good Wikipedia dive, I'm sure, if you're more interested in this. But yeah, ethics are really, really interesting. You should go watch The Good Place if you're into ethics at all. It's a good show for that. But regardless, let's get out of that interesting stuff. Let's talk more about the details. Like, we can't even get to the ethics if we don't even know how to run a study yet, right? That's the thing we need to look at. So, anyway, I'm still surprised. 43 of you joining me. That's fantastic. 2/3 of the class here with me. It's perfect. So anyway, now I want to talk about p-values. I'm sure a lot of you have heard about p-values, and we've talked about, loosely about things like significance before. Like, what is significance? I mean, like, if you say someone's your significant other, that certainly means one thing. And just because I say something is statistically significant, that might not mean a whole lot, right? We'll talk about clinical significance. So significance is a significant term, and we're going to have to define it, and it's going to be useful to look at p-values as well. Okay. Here's the objectives we're going to look at. We'll go back to this in just a little bit to the individual points here. So introducing the p-value. We're going to talk about hypotheses. We're going to talk about the null hypothesis. Even though we disprove the null hypothesis all the time, there's always new ones to disprove here, right? Anyway, so let's say, for instance, we are flipping a coin. Oh my goodness, I'm so sorry. I'm still getting used to doing these. All right, PowerPoint's up now, right? See it? There's a little thing there. I assumed you guys were just at ESPN and could know what I'm looking at. All right, we're back on track. Oh my goodness. Okay. I'm still in, very early on in my streaming career, so I got to work on some of these transitions here a little bit. So please forgive me. Make sure to smash that subscribe button. Click the like button. Do all that good. I'm just kidding. Don't do that. It only serves to boost my ego even further. Okay, so getting into our p-values here. So let's say, for instance, we are flipping a coin. We have a typical quarter, no biases for heads or tails, and we flip it 20 times. You would expect, if you did that, that you should get 20 times, you get 10 heads and 10 tails, right? It'd be a 50-50 shot in terms of what you're going to be getting there. Some streams cutting out a little bit, looking a little better now. But so let's say, for instance, though, we flipped that coin 20 times and we got 16 heads and 4 tails. Now, how unlikely is that to actually have occurred? Because like I said, you're assuming it's a 50-50 shot if you're going to get heads versus tails. So you would expect to get 10 heads and 10 tails. So how small is that probability of actually getting 16 heads there? This is what is going to be kind of what we're talking about from here on out. And what are the probability of getting the results that we find versus just chance alone? And so this is where we start to get into our hypothesis here and talk about hypothesis testing. And p-values are going to be really helpful in helping us to determine whether we should accept or reject our hypotheses, right? So when I talk about the null hypothesis, basically what it means is that there's no difference between the two things that I'm comparing, right? So if I'm flipping a coin, I'm assuming that the coin is fairly balanced. It should be landing on heads 50% of the time and tails 50% of the time. So my null hypothesis is that there's no difference between whether I'm going to get heads or tails. It's 50-50. Okay, that's my null hypothesis. If I were to then flip that coin 20 times and I get something like 16 heads, I need to figure out how likely it is that that was just due to chance alone, or is there something up with that quarter? Maybe there's something that's biasing it towards heads more so than tails, right? And what you're going to find is that in medical research, we're going to be establishing a null hypothesis as something that we want to reject, right? So for instance, if I was using, let's say I had a new drug that I wanted to try out. Let's say that I have, let's go back to the example of remdesivir, right? That's a new antiviral that's in the clinical studies to see if it can treat COVID-19. So let's say, for instance, I'm using, 100 patients with COVID-19. I have 50 of them are going to get remdesivir and 50 are going to get placebo, just a sugar pill, right? Or fake injection, whatever route you want to use. So in that case there, my null hypothesis would be, and if my outcome, I'm looking at survival of COVID-19, right? So survival 1 year or something. My null hypothesis would be that there's no difference between the groups. The remdesivir is going to do nothing to survival. The placebo is going to act just the same. There's no difference between the two groups, okay? I'm hoping to reject that null hypothesis and say, no, remdesivir actually does improve survival when compared to placebo, okay? So that's often what researchers are doing, trying to disprove the null hypothesis by showing results that show that the results that they found are very unlikely to be due to chance alone, okay? They're saying there's no way this is 50-50. There's got to be something going on here, okay? So as I mentioned before, if we were to actually look at the stats on it, if we were to run, say, 100 trials of flipping that coin, we'd probably get something pretty close to a bell-shaped curve. We'd probably get a normal distribution where the average is probably somewhere around 50% heads, right? And so we're saying, well, what are the chances are that we're actually going to get 16 heads, right? What are the chances we get 16 heads or even something more extreme like 17, 18, 19 heads? Well, the chances of that happening just by chance alone is 1.19%. So I should only get results of 16 heads or more roughly 1% of the time. If I were to do that 100 trials, I'd only have it happen one time, right? And so this is what we're talking about is the p-value. We're saying that this is the chance that the results that we found are just due to pure chance alone, okay? So in this case here, the p-value for this of getting 16 heads is 1.19%, or as you might also see it, is 0.0119, right? Because remember, when we're converting over from percentage over here to the decimal place, it turns into 0.0119. Now, what we're saying here is when we're looking at a p-value is that we're saying that what are the chances the results that we found were just due to chance alone, or is it due to something else essentially, right? Is it, how likely is it that this is due to chance? And so when you talk about things like a p-value of less than 0.05, that is generally accepted as being the cutoff point for statistical significance, okay? We're saying that this is, if something is less than 5% chance just due to, or 5% probability due to chance alone, that there probably is a real statistical difference between these groups here, right? So if I were to look at survival differences between that remdesivir group and the placebo group, and the p-value that I got was 0.04, it would say that the results, the difference in results in terms of survival that I found was, if I ran the study 100 times, 4% of the time, it would just be, I would get the same results, which is very unlikely, right? 4% is very unlikely to normally occur. And so that's why we say if something's less than 5%, less than 0.05, the p-value is that we think this is statistically significant. This is very unlikely to be due to chance alone, especially in the case like 0.0119, 1.19% chance this is due to chance. That doesn't seem likely, right? So because of that, we can then reject the null hypothesis and say that no, there's a difference here, okay? So as I mentioned, null hypothesis is just stating there's no difference in the population parameters amongst the different groups that I'm comparing, right? So if I look at, a group of people getting a new blood pressure medication versus placebo, I would say that the blood pressure differences between the groups at the end of the study are going to be due just to chance alone. They're no different than one another. The drug is having no effect on those patients. That's the null hypothesis. And that p-value is telling me what are the chances that the results that I do find are just due to that chance alone. But the more I kind of think about it, I think it helps to make a little bit more sense, especially when you start to read some studies with these journal clubs. I think it should make a little bit more sense to you there. But basically, the smaller the p-value is, the stronger the evidence is that I can disprove that null hypothesis. I cannot accept that null hypothesis. And does that mean the null hypothesis is not right? Not necessarily. There's still a chance, right? Because even if I hit something that's a p-value of 0.05, there's still 5% chance that I'm wrong, that the results I did find were due to chance alone. But the smaller and smaller that value gets, the less and less likely it's due to chance, and I can be more and more confident saying, again, here's where that term confidence kind of shifts a little bit. I can be more sure that the results I found do indicate a difference, and I can reject the null hypothesis. Okay. So again, as I mentioned, this makes a little bit more sense when we are looking at a graph here, and I'll show you in just a second here. Oftentimes when you're looking at a study, there's going to be some Greek letters that pop up. And so what you're going to see is alpha. So when I'm referring to the level that a p-value has to get to in order to achieve statistical significance, that's going to be termed alpha. And most often is going to be 0.05. Okay, that means I have to get less than 0.05 to show that what I found is unlikely to be due to chance alone. I can reject the null hypothesis. Some places are going to get even more stringent. They say you have to be less than 0.01. You have to be less than 1% chance that this is just due to random variability, right? Just due to random chance alone. So the cases are once I get below that value, whatever I set my alpha to, whether it's 0.05 or 0.01, then I can reject the null hypothesis and I can say the results are statistically significant. So then Marley's asking, so it's basically to prove correlation then? Not necessarily, right? So we'll talk more about correlations a little bit later. We'll talk about causation too, and how those things are certainly not synonymous with one another. But it's just showing that the groups are different, right? So in the example of remdesivir versus the placebo, if the survival difference, if it's like, 95% survival in the remdesivir group and 80% survival in the placebo group, and I got a p-value that's less than 0.05, then I would say, okay, well, I can reject the null hypotheses, and the differences in these groups are very unlikely to be due to chance alone, and I can be more sure that the remdesivir actually had a benefit. Okay. Now, again, I'm just making up these numbers here, but I'm just trying to think of a salient example that's relevant to your potential life if you ever contract COVID, right? So could you clarify why values would be less than 0.05 versus 0.01? So that's based off the calculations, right? That's based off of the p-value that you actually get when you actually look at the differences between the group, and the statistical programs will spit out a p-value for you essentially. And again, what goes into making the p-value? I don't know. I don't really care to know that either. What I care about is getting the results back and then being able to interpret that. And again, the researcher sets whether they want their cutoff point to be 0.05 or 0.01. But we'll get more into alpha a little bit later here, and it'll make more sense. So Kelly's saying, so when birth controls say they are 99.99% effective, how does that relate? That's a good question. So, if I were to say do a study, and let's say I was using, let's see, using a method of, let's say just using condoms alone versus using birth control alone, you could look at the differences in pregnancy rates between the two, and then you could look to see if there are any statistically significant differences between those two based off of the pregnancy rate, right? When they say that birth control is 99.99% effective, it's just saying that they ran a study. They were looking at the number of women who were on the birth control. And again, what they say effective may change in terms of definition. But if it's pregnancy, they can say that, only 0.01% of women would become pregnant if they take this. Now, does that mean that how many people do they look at? That's a good question. But it depends on, the clinical trials and whatnot, how many thousands of people they actually looked at. So basically, that's more of a proportion of what they're looking at rather than getting a true p-value there. You won't see a lot of drug trials, touting, oh yeah, our p-value is less than 0.05. Like that's more for the studies themselves and the journal articles. So Nicole's asking, so if p-value is greater than 5%, that means that it wasn't due to chance. Also, what do you mean by statistically significant? Okay, very good. This is getting back to the heart of the matter. So if I get a p-value that is greater than 0.05, that means that it was more than likely just due to chance, or it's high enough that it's due to chance, high enough probability is due to chance that I don't want to say that I can reject the null hypothesis, right? And so this actually gets into our good point here when we're talking about things like false positives and false negatives. So this will make more sense in just a moment. So let me see if I can answer this for you and kind of get back to what I mean by statistically significant. So anyway, even though there's often confusion, as I am noticing here, which is totally appropriate, the p-value is not the probability that the null hypothesis is true or not, right? And it's not the same as something called type 1 error rate, which we'll talk about in just a moment. But when we say type 1 error rate, what we're referring to is the probability or the percentage of the time that we're going to incorrectly reject the null hypothesis, even though we should have kept it. And that's called a false positive. So if I were to say, remember when we talked about looking at the reason for hospital admission versus astrological sign? Remember how they kept running different comparisons? So they looked at CHF versus being a Virgo versus being a Leo versus being a Scorpio. When you keep running those things again, remember how I said even a blind squirrel can find a nut? You're going to find some statistically significant results just due to chance alone. Those are false positives. We know there's no difference between someone who is a Capricorn versus someone who's a Leo getting CHF. At least I don't think there is, but maybe there is. I don't know, but I'm reasonably sure there's not. So point being, though, is that there's still a chance you can come up with false positive results and say, look, there's an association here. Obviously this is the case. That's not always going to be clinically true, right? And so we need to be able to make a delineation between that. False positives are possible. Because again, we're saying it's less than 0.05. So that means that 5% of the time you can be incorrect. 1 out of 20 times you may incorrectly reject that null hypothesis when you should have kept it and got a false positive. Now on the flip side, though, you can incorrectly retain the null hypothesis and say, look, there's no difference between the groups, but there actually was. You just couldn't detect it. That's called a false negative, and that's a type 2 error, okay? This makes more sense when you look at this graph here. That makes more sense, right? So let's say I have the null hypothesis is either true or false, as you can see here, and then you either reject the null hypothesis or you keep the null hypothesis, right? If the null hypothesis is true and I do not reject it, so I'm saying there's no difference between these two groups, and there isn't, then that's a correct decision. I'm all good. Similarly, if the null hypothesis is false and there is a difference between groups and I reject it, then I'm good as well. That's a correct decision. However, if the null hypothesis is true and there's no difference between the two groups, yet I reject it, maybe I ran those different analyses over and over again until I found something that was significant, then that's a type 1 error. It's a false positive error, okay? On the other hand, though, if I have the null hypothesis is false, there is a difference between the groups, and I do not reject it, and I say, look, there's no difference here, that's a type 2 error. It's a false negative. Type 1 error is a false positive. Okay, and so these are things we're going to be thinking about in terms of what are the rates that these can occur based off the type of stats that we're using, based off sample size and all kinds of things, right? So anyway, so some pitfalls of the p-value, because a lot of people, especially if they're new to this stuff, will tend to hang their hat on the p-value and say, look, it's statistically significant. It's, less than 0.05. Then this has got to be a great drug we're using for these patients, or this surgery has got to be great for these patients. That's not always the case, though, right? P-value does not tell you anything about the effect size, right? So what I mean by that is, what if I go back to that example? I was comparing death rates between remdesivir versus placebo for treatment of COVID-19. I could find, if I did a large enough study, and I was doing like 10,000 people, and the mortality rates between remdesivir was, or say the survival rate was 95% versus with placebo is 94%. You can still find a statistically significant result there, less than 0.05, and say, look, there's a difference here. And that could well be true, but clinically, do you really care about a 1% change in survival? Maybe, maybe not, right? Or how costly is the intervention in order to do that? That all goes into making, into that calculus of really deciding whether or not this is something we should do or not do, as the case may be, right? So anyway, so another way to sort of illustrate what this looks like. So again, if we were looking at normally distributed curve here, and again, imagine flipping the coin. The most likely observation for something like flipping a coin would be 50-50, right? So it would be right here in the middle. This would be 10 heads and 10 tails if you did 20 flips of the coin. But you're going to find that you can get observations that fall outside of that. Maybe you have 19 heads and 1 tail. Or on this side, you have 19 tails and 1 head. Or I'm sorry, not that, but I should say 9 tails and 11 head, or 11 heads and 9 tails. But as you get further and further away, you're getting results that are less and less likely, right? So getting out to the point where I'm getting 16 heads and 4 tails is pretty unlikely. We said it was like 1.19%. So what you're finding is that you're seeing where that observed point is, and you're saying that what are the chances of me actually getting this result just due to chance alone? What's the probability of getting something this extreme or more extreme, moving to like 17, 18, 19 heads? What are the chances the probability that this is due to chance alone? And you're going to find that as you get further and further out, it's less and less likely to be due to chance. And so you can see with more surety, you can say that, yeah, this is probably actually, there's a difference here. And I can reject the null hypothesis and say, okay, well, yeah, this drug is making a difference, or this coin is not evenly balanced, or whatever the case may be, that could be affecting these results here. Okay. So as I mentioned, know the difference between a type 1 error, a type 2 error, what that means in terms of keeping or rejecting the null hypothesis based on your results, right? So as I mentioned, let's go back to that body temperature example where you're looking at average body temperature. We had a subset that was like 12 people and then 130 people, I think. So let's hypothesize here that the average population body temperature is 37 degrees centigrade. Yeah, on average, everyone on Earth has a body temperature of 37 degrees centigrade on average, right? So if we were to look at the data that we had there, and you were looking at 130 people, we found that their average was 36.82 degrees centigrade. And then we can develop a confidence interval based off of that. And what you notice here is saying that, okay, well, the confidence interval based off of this with 130 people ranged from 36.75 to 36.89. Okay, so it's saying that the actual population average based on this 95% of the time the actual population average would be somewhere between 36.75 and 36.89. However, it did not include 37. So what's going on here? Is it that these results are wrong? Perhaps, but maybe there's some other things that are going on here as well, right? And so perhaps we sampled a subset of people who happen to run a little colder than the average. Who's to say that the actual average temperature is 37, right? Is that just something that we've just carried on with history forever, that we just think that that's the average, or is it just an easier number to remember? That's probably more the case there. But what you can see here is comparing what you think is the actual chances of getting a result that different from your population, right? So what are the chances that these results here, it's a probability that these are due to chance alone versus there's a true difference between these people here and the average, right? So I can actually calculate that and get a p-value to see how likely it is that I got these results due to chance alone. And so what you actually do is you can figure that out, and you can see here is that the p-value, and again, here's another way you could word it, say if the population mean truly is 37 degrees centigrade, what is the chance in a sample of 130, the absolute mean value of the discrepancy between the sample size is 0.18 or larger? Okay, so what I'm saying, what are the chances that I'm going to find this discrepancy here with that sample size? And the p-value would actually equal 0.00000018. This is extremely unlikely to be due to chance alone. So either these people are really different than the average, or something else is going on. Maybe this 37 isn't inaccurate, right? But it shows you that this discrepancy here is just very unlikely to be due to chance alone. I can reject that null hypothesis that says that there's no difference between the larger population and the group that we were looking at, okay? So again, the smaller that p-value is, the more likely I am to reject the null hypothesis, even though the discrepancy is infinitesimal. I mean, it's like, who cares? 0.18 degrees centigrade does not make a huge bit of difference on the grand scheme of things, right? It's just telling us that those results are very unlikely to be due to chance. And so again, how firm are we on the data that the average temperature is 37? Maybe this is just a convenient number to remember versus 36.68 or whatever the case may be. And so again, you have to look at what your assumptions are and see which ones are being violated there, right? So let's look at a different example though. Let's look at that smaller subset of 12 people. Remember that the smaller our sample size is, that larger the confidence interval is going to be. So when looking at the confidence interval here for the 130 people, notice it was very tight, 36.75 to 36.89, very tight differences there in the confidence interval, right? Very close to the actual average they got. If I'm just doing a subset of 12, what I'm finding here is that the confidence interval has a much wider range. It goes from 36.51 all the way up to 37.02. Now notice the confidence interval does include that average of 37 that we mentioned before. Now let's look at our p-value as well. And typically what you find is that the bigger the sample size is, the more degree of certainty you can come to with your p-values, and the smaller they tend to be. In this case here, the p-value happened to be 0.0687, so it's greater than 0.05. So what does that mean? Right? Because before here, we rejected the null hypothesis and said this is very unlikely due to chance alone. There is some difference between the larger population average temperature and the one that we collected from this 130 people. Well, looking at this 12, now that this is greater than 0.05, we are unable to reject that null hypothesis. We said, well, based off of these results, it could be due to chance alone in 6.87% of the time. So I'm going to keep the null hypothesis and say that there's no difference between the groups. Now, does that mean that there really is no difference? Maybe, and that would be a correct assumption there, but it would seem to be unlikely based off of what we saw with the larger sample set here of 130. So maybe this is actually a false negative. Maybe that's a type 2 error in which I should have rejected the null hypothesis, but could not based off of the results that I got here. And there's going to be some reasons why that is a little bit later when we talk about sample size and how that has an effect on being able to detect a difference if one truly exists, okay? And again, remember, the reason why the confidence interval is wider is because that standard error of the mean is going to be a lot larger because our sample size is so much smaller. It's almost 1/10, a little less than 1/10 of what we have when we're looking at the N of 130, right? So there's another concept here too of talking about one or two tail p-values, right? Because again, when you're looking at that graph here a second ago, you notice that the results could go either way, right? It could skew more towards heads or it could skew more towards tails. And so when I say tails here, I'm referring to the ends of these bell curves here, right? So one tail would just be one side of the graph, two tails are going to be two sides of the graph. And I'll show you what that looks like here in just a moment. So basically, you have to distinguish, or researchers will distinguish when they're trying to make a comparison between groups or a group versus a population, whether or not they're going to be using one-tailed or two-tailed p-values, okay? If you hear one side or two side, it means the same thing. And so basically what this means is that you're making a guess on which direction the change is going to be from one on one side or the other. Or if you're not sure which way it's going to go, that will lead you to choose one versus the other, okay? Let me show you what this looks like. So here is, again, a normal bell curve. I apologize, this contrast is a little hard to see here, but you get the main curves. So again, when I'm looking at something, so let's say I was looking at the temperature comparison again. So I said the average was 37, and I want to compare my group data to that average of 37, right? Well, I don't know if my group is going to be higher or lower, so I want to hedge my bets and make sure I'm using both sides of the curve here in order to determine if there's a statistically significant difference. I'm not sure if they're going to be higher or lower, they could be the same, but because of that, I can go ahead and use a two-tail p-value, right? So basically, I have to get to a certain point on either end of these curves here to achieve significance, Okay. Now what you're going to find here is that when you're using a two-tailed test, that 0.05 kind of gets divvied up between either side here. So they'd actually have to get less than 2.5% or 0.025 on either end here to achieve significance. We'll talk more about that a little bit later. Now, two-tail value is going to be helpful if you're not sure which direction or which group is going to have the higher mean or lower mean. However, can be some cases where you can be pretty well assured which direction the group you're interested in is actually going to go, right? So for instance, if I had a drug where I was testing, let's say for instance, we were testing a new blood pressure medication, and I had one group receive placebo and the other group receive an antihypertensive, I probably would not guess that the group receiving the antihypertensive is going to have a higher blood pressure than the placebo group, right? It would seem very unlikely for that to occur just based off of the fact I'm introducing an antihypertensive. So in those cases there, I could reasonably well assume that the people receiving the blood pressure medication are going to have a lower mean than the people receiving placebo, right? So in those cases there, if I have a pretty good idea which direction the mean is going to be shifting, I can use a one-tail t-test instead, right? What if on the case here, where if I was looking at that example of placebo versus remdesivir for COVID-19, what if remdesivir actually is like harmful? What that actually causes mortality versus lowering mortality because it's helping you to cure COVID-19 faster? Well, in those cases there, if I'm not sure which direction it's going to go, I'm not sure which group is going to have the higher mean survival rate, then in those cases, I would use a two-tail test or two-tail p-value because I'm not sure. Okay, so if you're pretty reasonably assured which direction is going to go, then you use a one-tail test. Now, does that mean that the results can't buck that trend and actually go the opposite direction? Yeah, but then it's going to screw up your study results here, which I'll mention at a later time. So another example here would be a one-tail test would be, for instance, I'm trying to see if I have the example here. Again, this is just re-illustrating the fact that if you think the value is going to head in a certain direction, you're pretty well assured, then you go ahead and use the one-tailed test here. So here's a good example here. So imagine you're looking at antibiotics and you're looking at their ability to impair renal function as measured by the serum creatinine, right? We kind of alluded to this already in Farm, but imagine you're trying to compare antibiotic and versus placebo to see changes in serum creatinine. Well, if someone's receiving a sugar pill, I'm pretty well assured they're not going to have their GFR and the serum creatinine change very much. But with the antibiotic, you would assume that the creatinine clearance is going to go down. The GFR goes down, serum creatinine goes up, right? So as serum creatinine goes up, GFR goes down. But I certainly am not going to assume that the antibiotic is going to lower the serum creatinine, right? Because in those cases there, it's not going to improve renal function. So because of that, you can reasonably be well assured that I can just use a one-tail test and look to see if the average creatinine is going to increase for the people getting the antibiotics. So you can kind of make some sense of that when you're looking at journal articles, what type of test they should be using based off of the type of intervention they're having. So if you're not sure which direction is going to go, then go ahead and use one two-tail there, okay? When you say, what do you mean by head in a certain direction as in closer to the mean? I mean, if you were to compare mean values between two groups, when I mean when you're looking at the average values, which one do you expect to lower or raise? So for instance, if I was looking at average blood pressure, average systolic blood pressure, and people getting placebo versus the blood pressure medication, I would assume that the people receiving the blood pressure medication are going to have a lower blood pressure. So it's going to be heading in the average is going to lower. So heading in that direction is kind of what I mean. So in terms of which one I think is going to have a lower or larger average. Okay. Average value, I should say. So let's see, where was I at? I'm getting a little squirrely here in terms of switching around my slides here. But so again, when you're looking at this example here of using the antibiotics as well in renal function, again, I can state that two possibilities are going to be that either the drug's not going to have any change on serum creatinine, or that the people receiving the drug are going to have an increase in their mean serum creatinine versus the population, or versus someone receiving placebo, for example there. Again, it's very unlikely that the antibiotic would cause the serum creatinine to lower, right? So anyway, so when you're looking at, one-tailed tests, you can see here that this is helpful because it basically is saying you already know which side of the curve you're looking for in terms of your values there. So you can kind of lump all 5% of that onto one side, as opposed to a two-tailed test. You kind of have to divvy it up and either achieve 2.5% on either end, which I'll show you what that looks like in just a little bit here. But again, with the one-tailed test, the p-value would tell me, again, that change in serum creatinine, how likely is it that that is due to just chance alone, right? You'll see that two-tailed tests are used typically a little bit more often than one-tailed tests. For one, because it allows you to, if you're not sure which direction the average is going to change, whether higher or lower, it gives you a little bit more safety there in terms of being able to determine differences if it goes up or down, as the case may be. And they tend to be more conservative. So when I say conservative, what I mean by that is that they are less likely to show a true statistical difference. And you're like, well, that doesn't sound like a very good thing. But basically, if you were running an experiment, you would rather likely to, you don't want to show a false positive, right? You don't want to say something is different when it really isn't, because that may lead people to change therapy. It may lead people to decide to go with one treatment versus another, which can have pretty drastic outcomes. So you'd rather show a false negative than a false positive in general, right? Because if I get a negative result in the study, well, I can then go and try to rerun that study, for instance. But if I show a false positive and I show all these people, look how great this new drug is, and they start to use it, but that was actually a false positive, that's not great, right? And so you'd rather make a false negative than a false positive, as the case may be. So when I mean that tests are more or less conservative, more conservative means it's more difficult to achieve statistical significance. The math is just making it more difficult to get that p-value less than 0.05, as the case may be, such that I'm more likely to make one of those type 2 errors. I'm more likely to say there's no difference here when there actually is, okay? So, but that's generally going to be an okay thing. There's going to be limits to all of that, right? So there's pluses and minuses to both. But generally, when I say things are more conservative, it just means you're more likely to make a type 2 error. You're less likely to reject the null hypothesis, and you are going to say there's no difference between the groups when maybe there is, but it's just one of those things where you're kind of trying to be more conservative, right? So anyway, so as I mentioned, when you're looking at tests that will compare 3 or more groups, you're going to see that this becomes a little bit more difficult to kind of ascertain, tails here in terms of one tail versus two tail. So just in general, we end up sticking with two tail tests for the most part, because again, being a little more conservative typically is a better scientific method, I guess. So let's see, I got a few more minutes here to talk. So let's talk about statistical significance and hypothesis testing. So now we have a decent idea, I hope, of what an actual p-value is and what it's trying to tell us when we're evaluating one of those in a study, right? And remember, p-values don't have anything to do with the effect size that you find, right? It doesn't tell you how big of a change in blood pressure there is, doesn't tell you differences in survival rates. It's just telling you how likely that what you found was to be due to chance alone, okay? So anyway, we're doing statistical hypothesis testing. Basically, it's going to be following these steps here. So one, you have to define a threshold for your p-value to declare whether you think something is statistically significant or not. And this is going to be denoted by alpha, right? As I mentioned, alpha is most typically 0.05. So if I achieve something less than 0.05, then I say that that is statistically significant. If it is above 0.05, then I say it is not statistically significant, in which case I cannot reject the null hypothesis. Now, can I change alpha to something else? For sure. It's just by tradition, 0.05 tends to be the most common. I could say 0.01, which is going to make it more difficult to achieve statistical significance, but that's also more conservative, right? It's harder to find something that only happens less than 1% of the time than it is to find something that happens less than 5% of the time, right? More conservative, but you'll find that 0.05 is still far and away the most common here. So, and again, we're going to find is when I say hypothesis testing, it has a kind of a unique meaning here in statistics versus maybe some of the other ways you've kind of heard it denoted previously. So kind of when we're doing these studies here or evaluating these studies, we kind of want to think of it kind of like you're prosecuting a crime a little bit. And so you have to go with the mantra kind of innocent until proven guilty, right? Not going to make any mention about actual court systems and how they're working, but let's go with the ideal here that everyone's innocent until proven guilty. And so again, this presumption of innocence, if we wanted to sort of find an analogy to that with our statistical analyses and our studies, we would say that our presumption is that the null hypothesis is true, right? That there's no difference in between the two groups that we're looking at or between our group and the population, whatever comparison you're actually doing here. And then we're going to present the facts, right? So this is where you're going to use the data that you collect, right? You're not really looking at outside information. You're not looking at outside circumstances. You're just using the data that you're collecting from your sample set, right? Whether it be 10 people or 100 people, or whatever the case may be. And then you get the verdict, right? Now you don't need to require 12 people to agree on something in order to determine if you can reject the null hypothesis or not. But what the verdict is going to be when that p-value comes back. And if that p-value is less than your alpha, which is usually 0.05, then you can say that it's very unlikely that that null hypothesis is true, and then I can go ahead and reject that, right? So I can say, okay, now that I know you're guilty. But if the p-value comes back and it's greater than my alpha, if it comes back at, say, 0.06 or 0.1 or whatever the case may be, much greater than 0.05, then I can say, well, I can't really say that there is a true difference here. I'm going to go ahead and keep that null hypothesis, and we find the verdict is innocent, right? Just carry this analogy forward. I wish I had that Law and Order sound, the gung gung sound on hand, but unfortunately I did not prepare for that. But again, what we're saying here is not necessarily saying, innocence versus guilty, but we're saying more so that what conclusions can we make about that null hypothesis? Can we reject it versus accepting it? When we accept it, we say, yes, it is true, there's no difference here, versus rejecting it, saying, no, there is a difference, okay? So when is this testing useful? Well, it's commonly used in a lot of things, like quality control, for instance, sometimes exploratory sort of research here. And again, it can be sort of counterproductive to reach a definitive conclusion of statistical significance, right? Because you can find things that are statistically significant all the time that clinically don't really make a whole lot of difference. And so this is why you have to make sure that you don't hang your hat just on a p-value, and instead look to see what are the confidence intervals, what are the clinical differences here, and do I actually care about that, right? Again, do I care about 1% change in mortality? Maybe. Do I care about a 2 millimeter mercury change in blood pressure? Probably not. It all depends on what your what your perspective is and what you're looking at specifically. So again, when I say something is significant or not, does it matter how significant it is? Not generally. If it's below your alpha, then it's just statistically significant. It doesn't make a result of 0.004 any better or worse than 0.04. It just means that it's very unlikely that the result you found is less likely to have occurred due to chance alone than a value of, say, less 0.04, for instance. So, but clinically, it doesn't really make a whole lot of difference here. As long as they achieve a value less than their alpha, then they're okay to go ahead and reject that null hypothesis. Okay. However, what if something is borderline statistically significant? If something can have a p-value of 0.049, which would be significant, but 0.051 is not, this is where you have to use a little bit more of your clinical acumen, your critical thinking here to sort of make determine a difference here. Something can trend towards significance, but not be statistically significant. Does that mean that those results are completely invalid? No, it could mean that you need to run the study again. Or maybe you had too small of a sample size and you couldn't find the difference because your study was underpowered. We'll talk about power a little bit later on in this course here. But again, it's important to take the p-value into context and don't just go ahead and hang your hat completely on, p-value less than 0.05, so these results must be good. Not quite that black and white, unfortunately. So why do we choose a significance level of 0.05 versus 0.01? Well, there's going to be a drawback to either going the p-value too high or too low, and it has to do with our rate of making type 1 versus type 2 errors, right? So if you recall, type 1 errors when we say that, yes, there's a difference in the groups, but there's really not, and we falsely or incorrectly reject the null hypothesis. Type 2 errors when we incorrectly keep the null hypothesis and we say there's no difference when there truly is. You remember I said that clinically you're better off making a type 2 error because you can always run another experiment. The type 1 error, though, people typically take those results and run with them, and unfortunately there's not as much validation of study results as you would like to see, right? One positive result can propagate itself and all of a sudden it's on the news and everyone thinks, hey, this is the greatest thing since sliced bread, and then you tend to find years later maybe it's completely terrible, right? Because no one ever actually went through and redid the study. But so if I set the p-value or the alpha very low, I'm going to make very few type 1 errors, right? So if I say you have to achieve a level of significance of 0.01 or less, right? That's my alpha, 0.01. If you get below that, then it's very hard to find results that will be that that unlikely to be due to chance alone. So I'm going to make very few type 1 errors, which is a good thing, right? So you're saying, okay, well, that's great. Why don't we just make that p-value or that alpha as low as possible, because it means I'm going to be making less type 1 errors. Unfortunately, though, if you set it very low, you're also going to be making way more type 2 errors, because it's going to be so difficult to achieve significance that you're going to have results that may actually indicate a difference between groups, but you're not going to be able to accept that because you set your alpha at 0.01 or 0.001 or whatever the case may be. And so that's the downside of it. So a lower p-value or lower alpha means you're going to have fewer type 1 errors, more type 2 errors. And again, that can be okay to a point, but you don't want to get too carried away with it. Otherwise, you're never going to ever reject the null hypothesis, and you're never going to be able to find any actual results here. If I go with a higher alpha level, so if I went, say, from 0.05 to 0.1, for instance, I'm going to be making way more type 1 errors, but I'm going to be able to achieve a significance pretty easily, and so I'll have fairly few type 2 errors. That's kind of the difference here, kind of the drawbacks of using a lower or a higher alpha in terms of achieving statistical significance. Okay, so we stick with 0.05 for the most part, unless you want to be extra conservative, and then you go with 0.01. Okay, because again, when you're looking at statistical significance, even at an alpha of 0.05, that means I'm having a 1 in 20 chance that I'm making a type 1 error, right? My value comes like 0.049. That's still 4.9% of the time you're making a type 1 error. And so what you're going to find is that it's generally good enough for our purposes here. If you find a result that comes back at less than 0.0001, you have to interpret that. You'd say, okay, yeah, I know that's very unlikely to be due to chance alone. I know that's very unlikely to be a type 1 error if I go ahead and reject that null hypothesis. But you'll find your p-values will differ from one sample to the next, even if you're using a truly random sample from the same population. You're going to find that p-value will shift over different experiments as it's being run, right? If you go back to that confidence interval example I saw with the beans in the jar, where the population mean, even 5% of the time, that's going to be incorrect, right? So it's kind of a similar thing here. Now, let's see, how much time do I have left? Not much time. I don't think I have time to get through the rest of this. So I'm going to go ahead and probably cut it off here and see if you guys have any questions. So feel free to post up anything in the chat. If I didn't make anything clear, let me know so I can go ahead and try to clarify that with the 7 minutes or so that I have left. Let me see if there's any questions up here on the sticky board, which is now displaying because I made sure that it was displaying. Let's see, do you have any suggestions for resources such as books that can help with studying this material? Good, so this kind of goes into how to study for the class. So in general, what I would say is have a pretty good idea of definitions of your, understand the definitions of the different terms we're talking about here. There'll be some easier questions where it'll be like, which one of these is the definition of a p-value or of alpha or something like that. I'll ask a few easier questions, which is just rote memorization, but you guys may not know this about me, but I don't like rote memorization very much, which may not seem congruent with the farm material so far, but I don't like this type of questions as much. So I prefer to ask more critical thinking type questions, more application type questions here. And so, being able to read a vignette and being able to look at the results of a study. And let's say, for instance, I were to give you a question where I said, there is, the study, you have these two groups here, and the p-value comes back at 0.06. What conclusions can you take away from this study? And you should be able to interpret that, okay, that p-value is not less than my alpha, so I know that I can not reject the null hypothesis because the results are not statistically significant, right? These are kind of the leaps you're going to be able to make in terms of your logic when evaluating these sorts of things. And we'll get there, right? We're still pretty early on. This is only the second class here, right? See, Isabel's asking, can you repeat the low alpha value? The slides say very low, you make few type 1 errors, and the next bullet point says if you set very low, you make more type 2 errors. Yes, that is absolutely true. So if we go back to here, again, there's going to be sort of a give and take between type 1 and type 2 errors. As you lower your chances for making type 1 errors, you're going to be increasing your chances for type 2. As you lower your chances to make a type 2 error, you're going to be increasing your chances to make a type 1, right? So there's a natural give and take there because of how difficult you make it to achieve significance, right? It's much easier, and again, you would have a easier time making a bet on a 1 in 20 chance of something happening than a 1 in 100 chance of something happening, right? The odds are just more in your favor. So that's why by setting the alpha lower, you have to get, so say if I go from 0.05 to 0.01, that means that I have to achieve a p-value of less than 1%, which is harder to do than something less than 5%. So that means that I'm going to be less likely to make a type 1 error just because it's more difficult to achieve significance versus when we make more type 2 errors, because now it is more difficult to achieve significance, and thus I may be falsely keeping the null hypothesis when I could have rejected it, because there is a difference between the groups. Again, on the flip side, if you increase your alpha, you're going to be making more type 1 errors, but fewer type 2 errors. So keep that relationship in mind between these two here. There'll be some more concepts later on we'll cover that will make some more sense with that. So another question on here was, do you have any suggestions for resources such as books? I think there's a lot of resources that are out there. Some people like the ridiculously simple series of books. You can find one on biostatistics and epidemiology. You can check that out if you like. Honestly, there's a lot of really good videos on YouTube as well. Right? So I'm not the only source that's out there talking about this stuff. I mean, Khan Academy I know is going to have a ton of really good sources out there. Keep in mind, though, you don't want to get too bogged down in the actual statistics of this stuff. You want to have an idea of how this is going to apply to more evaluation of the medical literature, right? So again, I don't care that you know how to calculate standard deviation. I more care that you know what it means and what it means in terms of applying it back to a study, right? Or that you know what the effective sample size is on the results of a study, what that does to power and what that does to your type 2 error rate and things like that we'll get into a little bit later on here, okay? So try to keep it something, if you can find like a medical channel. I don't know any specifically. I don't look this stuff up too often. But you know, try to find something maybe a little bit more medically oriented. If you can find something maybe like, you know, more med school based or something like that, you may get a little bit more pertinent things than it would be if you're trying to learn this from a statistician, because it's real easy to get lost in the weeds on this stuff. In terms of that. And I think when we go over our journal club, this will also make more sense as well, because we'll be able to see how we directly apply this information to an actual piece of medical literature, right? So there's some make some more sense when we get to that point, which will be coming up probably sooner than we know. So, okay, any other questions that I can answer for you? Ending almost perfectly on time. Get you ready for your next class. I don't know what your next class is, but hopefully it's a good one. Hopefully got your brain nice and prepared to check out whatever information is coming at you next. If nothing else, feel free to go ahead and head out. You can email me questions in the meantime if you have any. Otherwise, I will see you next time. I think next time we have probably Farm, if I had to think. Yeah, ethics are good. I would check out The Good Place. Really good series if you're interested in that sort of thing. Not that you have a lot of time to watch TV, but if you like ethics, that's a good one. Yeah, we have Farm tomorrow, so I'll see you guys all tomorrow at 2:30. If you're participating with interviews, thank you very much, and make sure you know, to give them what you think about the program so far. We're in a new world. Unfortunately, you guys are having you know, a very different experience than a lot of other students, but hopefully you're still enjoying your time, getting you know, your money's worth in terms of education. But let them know how it is. But hopefully we'll be back to normal in the winter, but who knows what normal is anymore. Anyway, guys, have a great day. I'll go ahead and end the stream now, and I will see y'all later.